Today, we are lucky enough to have well-known dentist, Dr. Andy Effting, founder and owner of Hout Bay Dental Studio, that will be sharing his immense knowledge of posterior indirect adhesive restorations. A founder member, immediate past president, and current treasurer of SARD, ITI fellow and director of the ITI Cape Peninsula Study Club, a national and international lecturer with numerous published articles. Be sure to follow Dr. Andy Effting and Hout Bay Dental Studio online to share his passion for dentistry and life in general. Andy, thank you very much for your time. It's a privilege to have you here today, and we look forward to listening to you. Over to you.
Good morning, Stephné. Can you hear me?
Yes, I can hear you, and your screen has been shared. Thank you.
That's perfect. Thank you. And good morning to all the participants of this webinar. And I'd particularly like to thank you and also Paula and then Ivodent for the opportunity to present this webinar on your platform. I'm really thrilled for that. And I'd like to welcome again all the participants. Thank you for joining and for sharing in my real passion part of dentistry, which has always been the posterior indirect restorations. Sorry, we're just trying to get the screen to move now. Did you get a black screen? Okay, there we go. Are we in business? So posterior indirect restorations has been my passion for a long time, and I ascribe much of the success of my practice to this very modality of dentistry, which, can you believe it, Stephné and delegates, that this has been around and available to us now for 35 years. And apparently it takes 35 years for a paradigm shift to occur, because prior to these beautiful restorations of veneers and posterior bonded inlays, onlays, we only had gold, or we could use porcelain fused to metal, which to me seemed to be a much more destructive and less invasive technique. So I was really very excited when this became available. At first it was almost too good to be true, and I persevered. It wasn't easy in the beginning, but now it's been simplified tremendously, and I sincerely hope that most of our colleagues are now very comfortable with this particular aspect of dentistry. As you can see, here's a study already, which was published in the Journal of Prosthodontics in 2012. And there was already then a 20-year study, a documentation available on the survival rate of inlays and onlay survival rate, a 12-year study. So as you can see from the slide, that even in the event of being a bruxer or a clencher, we still had very good success rates. The 12-year success was 92.4% for onlay, and 20-year success rate for inlays, 81.5%. So I'm sure that you can all agree that this is a extremely successful and acceptable treatment, more than acceptable, and ideal treatment in our protocols and in our armamentarium as dentists. Then Didier Dici and again published in the International Journal of 2011 an article, and they concluded that the preferred treatment today for heavily decayed large restorations, as well as for endodontically treated, and I'll get a highlight here, as well as endodontically treated or discolored teeth, the preferred treatment nowadays is overlays or onlays. And the alternative treatment would be a full crown. So I'm very happy to see that these bonded restorations today are the preferred treatment because they're much less invasive than a full crown, and they don't have as many complications. I'd like to go through the concept with you of the compression dome and the restorative implications. What happens in this article, also published in General Dentistry, October 2017, what they're doing is equating the enamel on the tooth to the dome, possibly of a cathedral. Those great grand cathedrals in the world like St. Peter's or, excuse me, or St. Paul's in London, where you have these magnificent domes. Now, if this dome gets interrupted and disrupted with a cavity or with a restorative procedure, for instance, an amalgam filling, then the tooth gets weakened significantly by at least 7 times. The beauty of this compression dome is when forces get applied to it, they get dissipated down the side of the tooth and they concentrate at the cervical region, which is then also makes sense when we look at the prevalence of abfraction lesions in these patients who brux and the patients who clench, because all the stresses are moved down there. So having said that, when this dome gets disrupted, that the forces then change and they dissipate through the dentine, and tensile forces are established which can lead to the cusp fracture. Fortunately, today we have bonded restorations. And when we apply our bonded restorations properly and place a dome over the tooth, as you can see on my pointer here. Can you see the pointer, Stephné? Does it come up?
Yes, I can, and it comes up as a red dot.
Thank you very much. So the compression dome on top would be a lithium disilicate restoration like Emax, and it's supported on the side by the biorim. Now the biorim has to be retained. The more you save of the biorim, the stronger the tooth would be. It's almost like it needs that to flex. It's like a tire with a tread on top, and then you have the sidewalls. So when you go over a stone, it can move. There's flexibility on that, which helps to reconstruct the tooth and improve its strength significantly. So effectively what happens is the dentine is replaced by the composite core, and then you have the ceramic layer on top, which has to be properly bonded with proper adhesive protocols. And when you do that, the tooth restores its strength to almost its original strength that it was. What I also like about this dome concept is that, as opposed to a crown, is that it's staying further away from the pulp, and therefore less chance to cause any pulp injury or insults. So these properly bonded ceramic overlays definitely decrease the risk and also the severity of a fracture as opposed to a crown. So I do believe that this minimal invasive technique is fantastic, and that it has protects the pulp significantly, because at all times we need to try and prevent injury to the pulp, because having to do endodontic treatments has its own complications. So let's look at this cracked tooth here, which you can see it's got the 7 in particular, it's got a mesiodistal crack through the center, and the tooth is very weak. But when you do proper bonding and you build up a composite core and retaining as much of that biorim on the outside and just cover it with a dome, then you'll get significant improvement in strength. I'd like to discuss a few important concepts in this presentation as well. And the first is immediate dentine sealing. Now, immediate dentine sealing is nothing new. It was already proposed by Pashley in 1992, and then Didier Ditchy and Magna in 94, and even later in the International Journal of Aesthetic Dentistry. So what it implies is it's an application of the bonding system to the entire dentine surface and applying it immediately after preparation, but before the impression. So I like this concept a lot. It's no different to when you're preparing for a normal bonded restoration. I like to use a selective etch technique with a universal bonding agent, and then we seal the dentine effectively right at the beginning. And what that does for us, it's established the immediate dentine seal, but it will reduce sensitivity on your indirect restorations tremendously, because the bond strength is increased. You can do a light cure to this product, and then you allow it to mature. And the maturation between now and your final fit really strengthens your dentine seal. This immediate seal also then allows for the placement of a composite base. So we're talking down in just the dentine optimization, and then we got the protection from the contamination of temporary fillings as well. So if you have a temporary restoration that falls off at this stage, your dentine will not again be contaminated. When it comes to bonding, even if you didn't build up a core in the stage, then with your cementation, you still only have two surfaces to contend with. We've taken dentine out of the equation, and as we all know, the dentine has always been the problematic part. So having taken dentine away, then we only have to bond to enamel and to resin. And it may even reduce the necessity for anesthesia during a fit. I'd like to, at this point also, while we just look at this slide, you can see that rubber dams are mandatory for bonding, and I'm sure that most of our colleagues should by now be very au fait with this technique. The immediate dentine sealing technique was officially recognized by the International Academy of Adhesive Dentistry. Way back in 2015 was this article published. I'd now like to discuss the cavity design optimization. And this refers to the application of a base liner. And the purpose of this is to optimize and to level the geometry of the cavity. So it makes a nice rounded feminine type curves into the tooth, which removes the sharp edges and which we don't want for bonding. It has a further advantage of reinforcing the tooth walls. So we no longer have to cut away sections of teeth where the undercuts are, and instead we can fill them in from underneath and thereby stay more conservative. It also can ensure for a consistent restoration thickness on top. Remember the picture of the dome, that we can then have a dome of even thickness and go for a more biomimetic restoration. Minimally hazardous dentistry then refers, I'm not talking in this instance about hazard to the pulp only, but particularly to the restoration. So when you do build up a composite core underneath to support your indirect restoration, it's imperative that you don't overbuild it, because if it's too high, then you don't leave enough interocclusal space for the thickness of the ceramic. And ideally on the occlusal side and in the middle fosses, you'd like to have 1.5 millimeters thickness if it's possible. You can get away with 1.2 millimeters, but don't put too much composite in there at the expense of the thickness of the ceramic. This cavity design optimization has a further benefit that it protects the dentine during the temporary stage. So should your temporary filling fall off, then there's no contamination. It also allows the thickness for the reactivation of the composite base prior to your final cementation and luting. So once I've built up my composite base, the cavity design optimization, then I will cover it with a glycerine layer to remove to make sure that the oxygen inhibited layer which otherwise would not set, will cure with your light. So deep margin elevation was the thing that really changed everything for us and really simplified the application of indirect posterior restorations. Because what this technique does for me, it really improves the marginal integrity of my final restoration. Again, it's not a new concept. It was also promoted by Manja and Sprayfico, had discussed it in 2012 in an article in the Journal of Aesthetic Dentistry, and then further again, Dici and Sprayfico and others, Internal Journal of Aesthetic Dentistry, volume number 10, in 2015, dealt with this issue in detail. So what we're really looking for is, and the difficulty with indirect restorations in the past was always the fact that when you come to bonding and your margin is subgingival, it would be very difficult to create a really good seal, and thereby you might get marginal leakage. So placing this deep margin elevation composite effectively brings the margin equi or supragingival, and we can really bond this deeper section of composite much more securely than what we can cement or lute the overlay at the end. And we'll have some cases to show at the end. So marginal integrity gets really improved, and you can see the beautiful emergence profile of the deep margin elevation here. It's important to try and get that S-bend. Of course, now that your margins are all supragingival, we also have a much simpler impression technique, be it digital with your CAD/CAM systems, or whether you're doing an analog impression. This really simplifies the impression procedure. It simplifies the rubber dam placement, which is of course very mandatory at the time of cementation. So your cementation procedures are much improved. It reduces the post-operative sensitivity because you have a better marginal seal. And then the cleaning and finishing of margins are also facilitated because they're supragingival, and you can see them and you can polish them nicely, and then you have no problems with the soft tissue inflammation if there were any overhangs. And it avoids gingival damages in the finishing process. So I know that could be a new concept for many people, the gingival margin elevation, and there's been a lot of studies on this in the last decade. And here's an article from the Journal of Prosthodontic Research. And what they said is the conclusion: on the basis of the reviewed literature, it can be concluded that currently there's no strong evidence that could either support or discourage the use of the cervical margin relocation, also known as deep margin elevation technique, prior to the restoration of these deep subgingival defects with indirect adhesive restoration. So what's very encouraging for me here is the fact that they're not discouraging the use of the deep margin elevation. And then further studies have also demonstrated that, so I'll move that across a little bit, have demonstrated from a clinical point of view, there seems to be well tolerated by the periodontium, provided a good bonding and proper isolation procedure was performed. So we're not saying here that there's no place for crown lengthening. Crown lengthening is still really necessary if the margins are deep subgingival and just above the osseous level. But often you have those margins that are just in the junctional epithelium area, and you need to bring them up. So from a histological point of view, it is clear that no connective tissue attachment could be formed on the material, and that a different kind of biological width was formed, which composed of long junctional epithelium. I want to move this down a bit. So if you look at the picture on the right, you can see that the normal junctional epithelium is 0.97 millimeters and the connective tissue is 1 millimeter. So if you have deep margin elevation, then it extends the length of the junctional epithelium, but a little less space for the connective tissue. Sorry, this thing is now not progressing again. Excuse me, I'm just trying to get the progression. So what's really important with the deep margin elevation is to try and maintain the emergence profile of the composite that you've built subgingivally, so that you can get a nice S-bend rather than an area where you're going to have an undercut, as we can see in this demonstration here. I want to just grab back my pointer. Excuse me. Get my arrow back. My screen is covered a little bit with the dialog box, so we're going to shorten that. So, okay, great. So now you can see very clearly where the better margin is and where the poorer margin is. So how we can avoid that, Garrison has already identified this problem, and they came up with a new type of circumferential band, or you can have it on a reel as well. And what it has, it's got the little cutaway that's so evident there. And the purpose of that is so that when you apply the band onto your tooth, that the band doesn't get deflected by the neighboring contact point. So the contact point would normally deflect the band inwards, and therefore the emergence profile is straighter. By cutting away the band, the neighboring contact point does not interfere with that band, and therefore a better emergence profile is created. So here you can see the band is in place, and we're doing the cavity design optimization. And when the band comes off, we've got a really nice emergence profile, as seen on the radiograph as well. So these bands are very useful. You can also take your own Toffelmeyer and make a cutout, as you see there, and that can assist in getting a really good emergence profile. So I'd like to go through a case or two to demonstrate all these principles. First of all, the isolation is really important. Now, I find the isolation with a rubber dam is particularly important, not only for the bonding, but also at the time of removing the old restorations, because I don't want my patients to swallow the amalgam or any of the mercury vapor. And now with the COVID as well, you'll see the new protocols also stipulate that rubber dam is mandatory. So rubber dam for placing it at this point is great because it facilitates the speed at which I can work. It removes amalgam very efficiently, and it enables my dental assistant to suction much more efficiently without all the water going down the throat. So here's my initial preparation, and as we analyze it, we can see that the margin is still very deep subgingival, and we also have in place the wedges. The purpose of the wedge is twofold. Number one, it protects my rubber dam, and secondly, what it does is, as I work closer with my burr, it doesn't drop down into the interproximal area and then causing a ditching on that margin. So the wedges are a great aid. So finally, of course, now we put our matrix band on and we refine the preparation. And the selective etch technique that we all know so well, I don't see any point in using the three-stage etch, rinse, and then the prime and bond type situation, because I don't want to open up the dentinal tubules if I can help it. Because once you've opened the tubules, you only then have to go back and close them up again. I'd much rather leave it undisturbed, and I think generally it's accepted that the selective etch is the way to go now. Excuse me. Of course, now we place our universal bonding agent, which we then dry out very well. Once you got it in, you've got to rub it for 20 seconds. And after that, you air dry it until the movement stops. And then you can light cure it with an efficient light. Then we can do our cavity design optimization as described, as well as the gingival margin elevation all in one step. And when the band is then removed, we can see that the margins are now very evident. On this picture, because it's taken from the top, it seems almost like a full crown prep, but I can assure you when you view it from the side, the bio rim is still all there, and most of the margin of the restoration is above the equator. It's my intention to keep the margins of all my overlays as much above the equator, which is the maximum circumference of the tooth, as we can, because that way you have no undercuts to deal with and you can be less invasive. So before you take the impression, we need to fulfill 5 criteria. The first being that you have to have detailed, sharply defined margins. These are really beneficial, and what we use here is to do a fine red ring or the yellow red burr, as well as the handpiece that we use is the red ring. The best I find is the electric motor with the red ring, and to just run it at a slower speed, and then you finish those margins with your fine finishing burrs, the chamfer type tapered burr. We're looking for an absence of undercuts, obviously essential to avoid any path of insertion problems when we fit our final restoration. The margins have to be accessible. The absence of contact with neighboring teeth, so we always look at the contacts and look at your path of insertion again to ensure that it's fine. If necessary, you can polish the margins a little further. And you have to have adequate interocclusal space. So now we sent the impression off to the technician, or you might have made a chair side on your CAD/CAM system. It's all the same. Then the typical traditional treatment of the ceramic was that you would do a chair side preferably, rather than let your laboratory manage your etching, because you can try it in and there's less opportunity for contamination. Once you've tried it in and adjusted it accordingly, we then etch it with hydrofluoric acid, which you will leave on for 20 seconds with lithium disilicate. After that time, we now need to rinse it, and then you have to remove your hydrofluoric acid salts. And that would, in the laboratory, typically they would use a steam cleaner. If you don't have one in your own office, then you can apply some orthophosphoric acid and rub that into the etched intaglio surface, and then rinse that off and dry. After you have a beautiful dry ceramic, you now need to then place your primer, your silane. And in this case, we're using the Monobond Plus. However, we're very fortunate that Ivodent and Ivoclar in particular have developed the Monobond Etch and Prime, which has really simplified the procedure. With this product, you simply apply it onto the intaglio surface, you rub it for 20 seconds, you leave it for a further 40 seconds, and then you can just rinse it under the tap, and then you're ready for bonding. If you look at the electron microscope slides here, you can see on the left, we have the Emax press etch for 20 seconds with hydrofluoric etch. And on the right-hand side, we've got the Monobond Etch and Prime, which has been rubbed on for 20 seconds and then left for 40 seconds to activate. And if we look then at how long-lasting and durable this type of product is, as opposed to the original protocol of hydrofluoric acid, then we can see that the Monobond Etch and Prime performs extremely well. This research was done at Ivoclar, Ivodent, Chan, and what they've demonstrated that after 24 hours, we have a very strong bond. But what's more interesting is after 10,000 thermal cycles, the bond actually strengthened, as opposed to some of the other products where the bond weakens with time. So to demonstrate, here we have the ceramic come back now from the dental laboratory, and we apply our Monobond Etch and Prime. It's a blue color, very easily visible. Rub it in for 20 seconds, leave it for 40 seconds, and then rinse it off, and then your overlay, inlay, whatever ceramic is ready for bonding to the tooth. This is a very nice kit and a nice product that I use for most of my ceramic bonding. And it contains the Monobond Etch and Prime, as well as the Adhese Universal Pen, which is the adhesive I use predominantly, and the Variolink Dual Cure Cement. So my patient has now returned and we're ready for bonding. Apply the rubber dam as always, and as you can see, we've definitely got a really beautiful seal around the tooth, and we invert the margins of the rubber dam to further improve the seal. Now we can do a total etch. There's no exposed dentine, so we're etching the composite, and we'll also at this stage etch the enamel. And once it's all ready and etched, you can see the beautiful surface for bonding. Now we apply our adhesive with the universal pen. As I said, rub it in for 20 seconds, and then you leave it for 40 seconds, and then you can rinse it. Sorry, my mistake. Sorry, apologies. We apply the dentine universal bond. You rub it on for 20 seconds and you air dry it to as thin as possible. And when it stops moving, you can light cure it and it's ready for cementation. Before I bring my overlay onto the tooth, then when we place it, and I put the floss in between in the interproximal areas to facilitate the removal of the excess cement. And there you have the finished product. And from the side, it integrates very beautifully. So if you look at the before picture of the fractured amalgam, which is the common problem we see in practice, that we now have restored it with an overlay, and how beautifully it integrates with the tooth structure. And if we look at the radiographs, the amalgam at the bottom, this is on the 6, as opposed to the 6 and 7 on the right-hand side, I think we've got a really nice end result. And also, if you look at the upper 6 and 7, the 1-6 and the 1-7, I'd done those the week before. I'd like to go through one further case with you. And this is a patient who arrived at the practice with some pain. I previously, a few years prior to this visit, we restored the 7. And we reduced the pain was coming from a crack cusp syndrome. If you look at the radiograph, the one I took in 2014, you'll see the big carious lesion on the mesial part of the 7. At that time, we addressed that with a glass ionomer base and a composite filling on the 7. And obviously, you can see that's the open sandwich technique with glass ionomer and composite. And 3 years later, it still looked in pretty good shape. Now that the patient has presented with pain on the 6 with the cracked tooth syndrome and also on the 5, we decided to do overlays. So the rubber dam gets applied and we remove all the amalgam. Excuse me. We remove the amalgam and then we analyze the cavity. So clearly here we can see there's still some deep marginal decay on the distal of the 6. And then on the 5 as well, there's a very deep margin. And also some decay on the premolar, the first premolar, the 4. There's also diastema mesial of the 4, and the patient did not like the aesthetics of that tooth because of the diastema, we decided we would then also do an overlay on the 4. So we get into our further prep, and you can see the wedges are again there to protect the rubber dam and also to protect the burr from falling into proximally. And now we're getting ready for our bonding. We place the matrix band, and I do a selective etch on the enamel margins. As you will see, I don't have to etch the entire enamel surface simply because I know that I'm going to freshen up those margins again later. The main thing is to seal the dentine. We apply our bonding agent, the universal bonding agent, and then the cavity design optimization together with the gingival margin elevation all done at the same time. The product I use for this typically would be a flowable bulk composite, and that works extremely well because there's low shrinkage, and I'm very confident that it cures well. It's really important to get a good seal at the cervical margin. When they take the matrix band off, we can now see we've effectively relocated that deep gingival margin and made it very, very much more accessible and supragingival on both the 6 and the 5. The 6, we've decided to just do an onlay with the distal palatal cusp overlaid. At that stage, I was doing infragum impression, and we're doing the analog technique with the bite registration. As far for the temporaries, I like to make a jig prior to preparation, and that will assist in the molding of the temporary. And that's the temporary coming out of the mold and the temporary in place. So these provisionals will perform pretty well for the week, and I'm very comfortable that my dentine is still extremely well sealed. The restorations get returned from the laboratory. We always inspect them to make sure that we're really happy with the quality, that has been well glazed, and that there's no cracks or micro hairline cracks in the ceramics. You can see how thin the margins are as well in this area, the buccal margin. So the palatal cusp is just overlaid, but the buccal cusp of the 4 and the 5, we took the margin down to just supragingival because of aesthetic reasons and for wanting to close the diastema. And again, we're using the monobond etch and prime, which you can see on the ceramic inlays. And that gets rubbed in again for 20 seconds, left for 40 seconds, and then rinsed. Back to the mouth to ensure that we've got a really good rubber dam again, and we've got proper isolation. It's very simple to place a rubber dam now because there are no contact points to worry about, and it just slides over very simply. And then when you invert the margins, we're assured of a good seal. Placing the wedge on the distal part of the 6 ensures that no cement will go subgingivally in that area, and it just facilitates the cleanup. It's very important if you do use a wedge in this situation that you go back and have a look before you cement that your overlay fits properly and that the wedge doesn't interfere with the fit. So here we are now with the cleaning of the overlay prep. After removing the temporary, I do like to use some air abrasion wherever possible, because that really gives a nice reactivation of that composite base. After, if you don't have an air abrasion unit chair side, then you can also use a pumice slurry or something like Proxit to clean and activate the surface of that composite. Then, of course, we go to our etching procedure. Again, I've got no problem with the etching here because there is no exposed dentine, so I just do a total etch and then apply the universal bonding agent. And as always, we rub it in for 20 seconds and then we blow it dry and light cure with an efficient light. With the cementation of this overlay, I decided to use a heat-cured, sort of a heated regular composite cement, simply because it's just easier to clean up. You can see if you do use your cements that you want to use should be low viscosity so that you don't get it running all over the place. When you get a beautiful bead of composite cement or composite extruding around the margins of your overlay, then it's really simple to clean. There we have that fitted, and then we decided to do the 4 and the 5 together So again, what's imperative at this point, after cementing the 6, you now have to try your 5 and your 4 in again, because often if there's a slight mis-cement or a tight contact, you don't want to find that at the time of placing your final restoration, when it's already ready and the cement and loaded with the luting resin. So this is trying to do that first, and also decide on the sequence of your cementation, whether you're going to place the 5 first or the 4. And again, that depends on your contacts and the path of insertion. So at this point, we again etch the teeth for 20 seconds, apply the universal bonding resin and light cure, placing your overlays into position and the floss into proximally, so that when you do a spot etch to cure it, you can best to use your light and just spot etch it, maybe 5 seconds buccal and 5 seconds palatal, or each corner of the tooth, and then you remove the excess cement before you do your final cure. And when you do your final cure, it's always a good idea also to cover your margin with a glycerine type gel to remove the oxygen inhibited layer. And there we have the final result. So looking at the teeth, once the rubber dam has been removed, we can see a very satisfactory result on the 4 and the 5 and the 6. Viewing it from the buccal and viewing it from the palatal, the margins are beautifully integrated. The occlusion is also very good. And you've got to check your bite and your contacts now, and you can adjust wherever necessary. If we look at the X-ray, it clearly illustrates the gingival margin elevation here, as well as here on the 5. And if you compare it to the 7, where we did it with an open sandwich technique and glass ionomer, it looks a lot more stable to do this with composite. So I really find that the gingival margin elevation is a wonderful technique to apply, and that we can move forward with this with a lot of confidence. So once again, I'd like to thank Ivodent for this opportunity to use their platform and for their wonderful service and products they present to us. And I'm available for any questions. Over to you, Stephné.
There you go. Thank you. Yes, thank you very much, Andy. We do have 2 questions. Guys, if there's any more questions that you're thinking of now, please pop it into the chat box and I'll get to them. Let's start with the first one from Dr. Mandy Ferrara. A nice and easy one, Andy. She's just wanting to know, do you only use analog impressions, or are you using CAD as well?
We use both, and you can go either way. I mean, not everybody has moved to digital yet, but it's this technique works equally well whether you're using digital impressions or analog. And I have both, and at certain times I use the one and other times the other, depending on the situation.
Okay. Another question from Dr. Muhammad Ibrahim. He's just, I think it's more a comment that you can just say yes or no. If I'm not mistaken, I think we should go over the enamel with a burr after IDS or deep margin elevation in order to remove the bonding agent from the enamel for a better bond with final overlay. I don't know if he's maybe referring to the sandblasting.
Well, firstly, if he's talking about the prep visit, once you've done your deep margin elevation or your cavity design optimization with the composites, you will then do your final refining of the prep. And at that point, you also take your very fine diamond and run it around the margins to make sure that there's no bonding agent on those margins. Excuse me.
So that's correct.
Then when it comes to the final cementation, of course, you will do a sandblasting or you clean with a pumice the cement and reactivating the composite. I really like to use my air abrasion unit, and it's very effective for that purpose.
That's really a nice tool to have when doing. Another question from Dr. Cosmos. Do you put the glycerine on before you light cure?
I first do a spot etch, the spot cure, sort of just 5 seconds in each corner, and then I clean up as much of the excess as I can, and then I put the glycerine over the entire tooth and the margins, and then I do my final cure.
Through the glycerine. Another question from him, what cement do you use for your temps?
Yes, we have there's a Telio temp, which is really very nice, a link that you can use for your temps, or you can use, there's also the Integrity, which I can use from time to time.
Yeah.
I prefer those two, the Telio temp or the Crown and Bridge temp from Ivoclar, or otherwise the Integrity.
I think let's make it a little easier for the delegates. That's when you are either cementing your temps that you have created indirectly, or alternatively, when you're using the Telio or the Integrity, it's more a suck down, shrinking type of bonding that you are utilizing, correct?
Yes. Are you talking about placing the temporary or the final?
No, the temporary. When doing the temps, you don't always necessarily cement your temps. Sometimes they also just shrink on over your preps, correct?
No, I make the jig before we start the prep. So if the tooth is damaged, I sort of build it up with some old composite just to create a shape, and then I take an impression with a rubberized base material, and then we will set that aside. And when it comes to the temp, I use my temporary material and inject it into the impression, and then place it onto the tooth, and then let it cure. When I remove it, then I always remove my temps, and then I finish them and make sure that the margins are really good. And then I will bond it with the temporary cement until the final is done. That's in those cases when we do use temps and we're using a laboratory and the patient comes a week later. Obviously, if you're doing digital chairside work, you don't need the temp.
Yeah. Okay, we've just got a whole lot of thank yous here. And then just your comment on the pulpal reaction to a glass ionomer versus a bulk full composite.
That's a very good question. You know, nowadays, we're mostly preferring to go straight with a proper seal. If I get a really good immediate dentine seal, and I haven't etched the pulp, I haven't etched the dentine at all, remember, then I cure that, and I find that the pulp reacts very favorably to my composite immediate dentine sealing. If there has been a lot of decay before, then often I can build up some glass ionomer base, but then I still want to do my immediate dentine sealing over that.
Okay, great. And that's all. Any other questions that is coming in? I don't have any other questions from my side. I don't know if there's anything else that you would like to comment or mention, Andy. From my side, there's no other questions.
What I would just like to say is that these protocols have really changed our lives and inspired me in my career. And for those who don't use these routinely, I would like to encourage you to investigate and implement these techniques, because they're extremely satisfying and the results are very durable. And I think we can move ahead with great confidence, knowing that it's a very valuable tool in our armamentarium.
There we go. Thank you very much, Andy. Be sure to register for Andy's full-day posterior indirect adhesive restorations course. That will surely change the way you do dentistry, or else for his full-day dental photography course. It's definitely the best and most informative dental photography related course available in South Africa, with a son-in-law that is a professional photographer, and he surely has some great tips and tricks up his sleeve. Andy, I think you will agree, in the case of ceramic restorations and with many other things currently in the world, less is more.
Absolutely. Thank you. Thank you, Stephné, and thank you to the participants for listening to my webinar. If
you have any topic suggestions for our lockdown sessions, please email info@ivodent.co.za. Catch this session to rewatch and all previous sessions on Ivodent SA's YouTube and the link on Facebook. If you want to be put onto the closed WhatsApp group, please send your cell phone number through to info@ivodent.co.za. Please join us Thursday, 30 April, that's tomorrow, for our lockdown live session at 11 o'clock with Dr. Mark Bose. Not every case can be bonded. Hope you guys all have a lovely day, and we'll see you back tomorrow, same time, same place. Thanks, Andy.
Thank you very much, Stephné. Bye.
Bye.